Good morning, Peter Goertz. I'm a psychiatrist. Let's talk about alcohol. As a psychiatrist, you're going to very frequently encounter patients whose mental state is affected by alcohol. And this past week, I saw one of those patients. So one example of what can happen is when I was a resident quite a few years ago, I was on call at night, and I got called to an orthopedic ward because a patient who'd had surgery, as far as I recall, maybe 2 days previously, started having hallucinations. And they didn't know of any psychiatric history in that patient. And when I spoke with the patient, it turned out he'd been quite a heavy drinker. And when he came into the hospital, they hadn't known about that. And he was not detoxed, and after 2 days, he started having pretty severe withdrawal symptoms, including hallucinations. So that's one example of what can happen and what can blindside people. So if someone's admitted for surgery on an orthopedic ward, you're not thinking of alcohol as your first issue. So then after a few days, if someone starts withdrawing, you can get blindsided and they can hallucinate on the ward and you're not sure why if you didn't think of alcohol. And the patient I saw this past week had an alcohol level over 260. So the legal limit generally, or at least often, is 100. So you'd expect someone like that maybe to be grossly intoxicated and unable to give an interview, unable to talk coherently. But this particular gentleman was totally able to converse and was able to give a coherent history. So it really varies quite a bit. If someone's a chronic alcoholic, a chronic heavy drinker, they can tolerate levels that would be very intoxicating for other people. So some people, some psychiatrists have a pretty steadfast rule. They don't want to interview a patient in an emergency room unless the alcohol level is less than 100. But often, in my experience, people are able to give a good interview, a coherent history, with a level of way above 100 if they're used to drinking a lot of alcohol. So it really varies from patient to patient. And you can use your judgment and maybe interview a patient even if their blood alcohol level is very high, if they're coherent. So the level does not necessarily, in other words, correlate with their mental state or with their mental acuity at that given moment. So signs of withdrawal would be tremor, psychotic symptoms like hallucinations, seizures, DTs, more or less in that sequence. So tremor, withdrawal tremor, which would be morning shakes, which people often experience, you'd see after about 8 hours of abstinence. Psychotic symptoms, hallucinations, maybe about after 12 hours. After 24 hours, you might have a seizure, alcohol withdrawal seizure, and DTs, so confusion, mental status that waxes and wanes, and continued hallucinations, DTs in other words, delirium tremens, you might see after about 72 hours. But that's just ballpark. So what I try to remember is 8, 12, 24, 72, tremor, psychotic symptoms, seizures, DTs. You want to get lab work in an emergency room, and things that can be a sign of alcohol use on lab work are if you scan the CBC, you might see a high MCV, you might see low platelets, you might see an elevated AST. All those can be related to alcohol use. Physical issues that can be related to alcohol, just a few examples would be cerebellar degeneration, so unsteady gait, neuropathy, which could also cause unsteady gait, and cardiomyopathy, so issues with the heart muscle related to alcohol. If the patient wants detox, you may consider detox in a hospital, or if they need to be in a hospital for other reasons, like medical issues or psychiatric issues. You're going to have to detox them in the hospital if they're going to have to be there for another reason. And for detox, you want to use benzodiazepines, and you want to use longer acting benzodiazepines like Valium and Librium, because that can create a more easy withdrawal from the alcohol, more easy detox because it's more gradual. The half-lives of Valium and Librium are very long, so they gradually taper themselves once you stop them even. So you might want to start just ballpark a Valium taper with 10 milligrams orally every 8 hours and monitor the vital signs, and then if necessary, you can give Ativan additionally as needed for signs of withdrawal. You also want to give vitamins. Unfortunately, a lot of people who drink alcohol do not eat a balanced diet with fresh fruit, vegetables, so they're going to be vitamin deficient often, and you want to replete thiamine, folate, and multivitamins. And another thing to think of, talking about thiamine, is Wernicke's encephalopathy. You want to consider in any alcoholic patient who presents. And Wernicke's encephalopathy is related to thiamine deficiency. And the symptoms or the signs would be ataxia, ophthalmoplegia, nystagmus, confusion. And the ophthalmoplegia generally is related to abducens nerve palsy, so palsy of the lateral rectus muscle of the eye. So that's something to keep in mind with any alcoholic, that the confusion may not be to alcohol intoxication or withdrawal even, but could be from Wernicke's encephalopathy or a combination of alcohol intoxication or withdrawal and Wernicke's encephalopathy. In any alcoholic, you want to consider falls. They often fall, they often hit their head, so head trauma can be an issue with alcoholics. And sometimes you want to consider getting a non-contrast head CT in the emergency room. And if the patient does not need to be admitted or want to be admitted for detox, you want to consider rehab. And the problem with rehab, of course, is it's voluntary, unless the patient is in the criminal justice system. And in that case, a judge could order rehab. So could say to the patient, you have to go to alcohol rehab or you're going to be incarcerated. Another thing to consider with any patient is Alcoholics Anonymous, AA. Thank you.